I'm Robert Stewart. I'm actually a GP, which I consider to be my privilege, and my main work is as medical director trying to look at how we could introduce more clinical commissioning and strategic change. So why am I driven for this, really? It's because we look at a thing called a primary care team, and increasingly we'd like to be a primary care, which is health and social care team. And I hear stories about how when things go wrong, because there isn't a communication between this team, and the team doesn't seem to be working together, and everybody thinks that there's been a breakdown in the system. But unfortunately, at the moment, I believe that is the system. So it's the system that we've got to change. We've got to try and use technology to try and make us into a real-time situation. So my story is one that lots of people will have heard, but it's a sad story. It's not like some of the success stories we heard from our patients earlier, our citizens and people earlier, because this is about somebody who had liver failure, and I told them when I went to see them that unfortunately no one else was telling the family that this person was going to die with his liver failure. And then actually what happened was he stopped breathing, and because his wife then phoned out of hours were very prompt, and they got us an air ambulance, and he was resuscitated, and he was taken to intensive care, and we used all of the resources, and this very wife finally caught up with her husband, with this rather distressed husband, and said, "Why is he in ITU?" And they said, "Well, because otherwise he's going to stop breathing." And she said, but Dr. Stewart told me he was going to die. I don't want him to die in an intensive care ward. I'm going to take him home. So she took him home, and he died a week later. And the sadness is that that's the sort of thing that can happen because we're not communicating across the different health and social care organisations. So I would suggest that actually we've been very slow at using this technology. I believe that the NHS is about 20 years behind, which actually gives us a bit of an opportunity because we can have a step change and we can actually start to use this third revolution, particularly around the smartphones. How can we change, not just having integrated care, but actually moving to interactive care, whereby with all of the organisations that deliver care so that patients don't have to keep repeating their story all of the time. And I would include health and social care and include out of hours and ambulance and hospice. So this is about some of that service change. At the moment, we need to change the whole culture of the way that the NHS works. When we don't know what to do about somebody, what we do is we so-called refer them, and that just means we push them around a system, as if having pushed them to that part of the system means that they don't need the rest of the system. And my view is that we should be moving much more to getting the enhanced opinion and advice so we get the right specialist input there, but not by pushing a patient around, but so that the other areas work in concert with that. And this will include interactive real-time records, at present based on the GP record potentially, so that everybody was able to see what everyone's role was in providing and meeting the needs of that patient or citizen. And we could also then move to sort of teleconferencing, whereby the team actually look at the holistic needs of a patient or a citizen and works out how best to meet those needs. And that would save everybody going all over the place. It would save the patient going to 8 different teams, but would allow the opportunity for all of those people to work together to deliver the best score that we can. And that would increase knowledge, it would increase education and training for all concerned, but most particularly keep patients in care as a key to that, and make the clinicians and social care professionals much more empowered and valued as members of that team, as opposed to having to make assumptions about what everyone else is doing within the team. And I think that's true of telehealth and telecare, of which I'm a great supporter. But at the moment, quite often, that information isn't available to the person who's making the crisis decisions. So we end up going back to the default position, which is sending them into hospital, whereas everybody wants the default position to be home unless hospital offers a particular advantage to them. And if we manage to do that, we would do all sorts of other sustainable things, like, because I know from my experience of my mother-in-law who had to attend hospital, getting to hospital is not easy. Getting people to take you to hospital and wait for you isn't easy. Why don't we use some teleconferencing type situations whereby patients and their carers can all be linked into this, and making sure then that they got the most appropriate advice that was actually going to meet their needs. It is to think about that we can use technology in a very different way. We could move, for example, to iPads for all members of the integrated health and social care team, so that they all knew what was being done and what the issues were and what the solutions that we've all agreed with the patient and the carers to take that forward. We know there are a lot of apps out there. You know, there was talk about what was the difference between telehealth and a stethoscope. Well, actually, under the new apps, you can actually listen to someone's chest. You can check their rhythm of their heart. You can get their blood pressure. You can get all of these things. But we're a bit slow on using some of those apps. But I know there's lots of good work going on out there. I know there are some social care projects around Amigo and Just Checking, whereby people with dementia's needs can be looked at in a different way. And wouldn't it be fantastic if you knew where your dementia patients were when they got lost and they wandered out of the house and no one knows quite where they are, such that my patient took the bus and it took 32 journeys before she got back home again because she got lost. We need to get into information as being key to that knowledge part of the third revolution, and we need to make sure that we can move all of those investigations, whether it be x-rays or records, personalised care plans. We could even have a situation with photographs whereby the nurse saw somebody with a bad foot. They could actually take the photograph on their iPad. They could send it to the GP, who could then send it on to the surgeon, and we could have a 999 ambulance, if it was required, straight away into an operating theatre for someone to have that ischemic leg looked at. These are all very possible with technology. We've just got to go through a culture change and a service change to deliver that. And as I've said, telehealth and telecare, and linking all of this to personal control, whereby the patient takes more control of this, is the way that we could go forward. So my revolution, as I keep going on, is around making sure that this is about the citizen. The health and social care professionals are there to help. We want them to be there to help, so we respond 24/7, not just when it suits the health and social care professionals. We need to make sure that knowledge is at the forefront of that, and that includes evidence, but it also includes understanding what are available and what are the options. And we should be using these smartphones, because that even, you know, many numbers of our population have got smartphones, and we can introduce those smartphones to people who haven't got those. So if we go back to the past, that was when we used to use paper records that often were miles out of time, so that the health professional was having to make decisions and assuming they knew what had been done in the meantime. We should be moving at the moment to real-time records at a GP level, but in the future, those records need to be held in a different way, and I believe that if we were to project forward, we would find that actually the person who owned those and held those would actually be the patient or the citizen that would be able to do that. So my view, therefore, is whatever, wherever, whenever, it's just to say that everything is out there to do all of this. We've just got to change the culture so that we really look at what the needs are, particularly as people go into more complex long-term conditions. Thank you.